Hello and welcome to Mindmine Mondays, another freewheeling conversation of the Mindmine Institute done in partnership with CNBC. This is live on CNBC, as also on all of the digital platforms of CNBC and of the Mindmine Institute. We've done 9 such shows and had wonderful freewheeling conversations with leaders from different walks of life. And today, the theme we are addressing is next generation healthcare, individualized, remote, connected, and platform care. And to have this conversation, we have an absolutely outstanding panel of Dr. John Halamka, who will just be joining us. He's president of International Strategy and Digital Platforms from Mayo Clinic. Dr. Andrew Badley, the chair of molecular biology at Mayo Clinic. We have Professor Solomon Darwin, the executive director of Center of Corporate Innovation at the Haas School of Business, University of California, Berkeley. We have Dr. Natej Buttar, the director of specialized endoscopic intervention and chair of GI endoscopy practice. We have Mr. Pankaj Patel, chairman of Cadila Healthcare, and co-moderating this session today with me, we have one of India's star, earlier a bureaucrat, and now the head of the think tank, Mr. Amitabh Kant, CEO of Niti Aayog, which is a think tank promoted by the government, which is doing absolutely amazing work right now, not just in thinking, but also in doing. Many of them, as you see, are actually professors, but we are going to hold the professors back from what they're usually able to do. They're normally able to walk around their classrooms when they're giving lectures. Today, they have to be bound in one place. And also, I'm going to request them not to give a long lecture, by the way, because there are so many of us, and we are trying to get a whole lot of things in. So what we would like to do is keep the questions short, quick, and snappy between Amitabh and myself. And I'm going to request the same of all of you to give us answers which are short, quick, and clear. And if you have any very technical terms to use, please do explain them in plain, simple English, because there is a very wide audience which actually logs on and watches this program. So thank you again. I'm going to let Amitabh start the session today with the first question.
So Sunil, first of all, it's a great pleasure being in this absolutely phenomenal panel. Let me start with Navtej, because this is truly the age of artificial intelligence. It's the age of data. And artificial intelligence has become more accurate in identifying disease diagnosis from medical imaging, and has become a very, very important source of diagnostic information. In the current decade, will artificial intelligence program be able to accurately diagnose various diseases and conditions? And I also wanted your views on whether are today's healthcare professionals prepared and ready for the era of artificial intelligence.
Thank you, Mr. Kant, and thank you, Sunil, for the invitation. Well, AI programs going to be a seismic shift in coming decades. AI is a big discovery, and I think it's as big a discovery as wheel. And Sunil can tell us that if you take the wheel out of life, we can nearly halt our life together. So while some future AI algorithms will become fully automated, many will continue to use human input and will likely to be our partners in diagnosis and streamlining how we manage our patients. So at Mayo, we use the ALP, AI and NLP algorithms to predict the nature of precancerous lesions. These algorithms are based on, because we have extensive documentation, lab data, imaging, and putting all that together, we can predict the risk of cancer and can decide which patient will be treated how, whether surgery is needed or whether we can just observe. Our cardiology colleagues have also used a very simple test, ECG, that you now can use and draw from a portable machine. It can really tell you the health of your heart and with what force your heart can contract. And what if your heart muscles are thickened, that can cause sudden cardiac death. So there was a great example. There was a patient whose early AI predicted age was a very old man, and then subsequently it was a 25-year-old man. And guess what? This was a patient with end-stage heart disease who then got transplanted with a young patient's heart. So, you know, the AI has great promise. Of course, there are issues such as high quality data and large amount of data that you need for training, and data from different healthcare environments will be different. So I think we're getting prepared, but there is a long road.
Thank you. Thank you, Navtej. And let me welcome John. John has just joined in now. Dr. John Halamka. John, I introduced you in your absence. I'm going to request you to move back yourself a little bit so you fit in the frame like everybody else. Perfect. And if you can move a little to your right, that'd be perfect. Just move a little bit to your right, so you're in the middle of the frame. Thank you. Amitabh, I'm going to ask you the next question. You know, all these folks at Mayo and other places have done amazing work on using technology, artificial intelligence, machine learning, etc. We in India launched an amazing app recently called the Arogya Setu. Can you explain what this is and the logic of launching it at this time?
So Sunil, the challenge right now for any country in COVID-19 is really about contact tracing. And Arogya Setu is India's mobile product, and for Bluetooth-based contact tracing, syndromic mapping, and information dissemination. And we've combined technology and data science to gain an information edge against this very unpredictable and very highly infectious enemy. We launched it on 2nd April 2020, and the app till date has seen more than 130 million registrations. It's the fastest mobile app to reach 50 million users globally, and it was one of the fastest entrants to the 100 million club. I think the app offers a very comprehensive suite of interventions against COVID-19 and has actually registered several firsts in the 10 weeks since its launch. The app possibly was the most reach and impact when compared to all other COVID-19 contact tracing and self-assessment tools. We have a dedicated team of about 100 doctors, and Arogya Setu has been providing the safety net of requisite medical advice to those who have assessed themselves high risk. The platform has reached out to more than about 800,000 users, and we have the reach of doctors in those in need. We've alerted more than 140,000 people so far of potential risk of infection through Bluetooth contracts traced from approximately about 30,000 users who have tested positive. The efficacy of testing recommended by Arogya Setu has been actually much higher than any testing protocol anywhere globally, and many folds higher than the current overall efficacy of testing in India, which is about 5%. And we have predicted more than 3,500 hotspots across the country at sub-post office level, and this has had a tremendous impact in India as far as contact tracing is concerned.
Those are staggering numbers. So thank you. John, I'm going to go a little bit beyond the COVID-19. We know we are in this crisis right now, but it would be a shame to have experts like yourselves on this panel and not ask you a little bit about the future. If you do some blue sky gazing, where do you think this connected world is going? At what point and to what level will tracking and monitoring actually develop and evolve? How connected will the physician and the patient actually get? Which means, are we going to be able to tell everything about a patient sitting at any one place? I don't know if we have John with us or we've lost him. We've actually lost the window.
I think the
okay.
I think he's coming back to it.
Yeah, I don't see him. Okay, let me go to Andrew. Andrew, talk to us a little bit about genomics as it develops into a full-blown science. Maybe it's not fair because it's been a science for a long time. As its application increases, let me put it differently. As its application increases in real life more and more, how far do you think this is going to step into being an actual treatment or a preventative?
I think those are excellent questions. In the realm of treatment, particularly as it applies to infectious disease, genomics was really one of the was one of the first places it was introduced was an infectious disease. And we all know that viral infections like COVID-19 are highly mutable and change over time. And that's inherent in the viral machinery, highly mutagenic, shifts over time. And what that means is that if there's a sufficient amount of time with exposure to drug, it's very likely that individual viral quasi-species will develop resistance. And having the ability to do genomic sequencing of the virus, separate from the host, allows us to tailor medications based upon genotype. And we've done that now for decades with HIV and done that now for decades with hepatitis C. And I think moving forward, that'll help allow us to predict which drugs to use in which patient populations. It'll help us predict drug susceptibility testing that's been done. And taking it even a step further, using artificial intelligence to map the stereochemistry of individual target viral proteins can allow for AI-informed drug discovery, which then we can move into testing and ultimately into patients. So genomic-based modeling is critical to a breadth of viral diseases and treatment options.
Thank you. So go ahead, Amitabh.
No, I wanted to turn to John Helamka, and I wanted to ask him as to how will technology and virtual formats, in your opinion, how will they help remove the administrative burden on physicians in the days to come?
Well, a fascinating question that you ask, and that is that I was involved in the Obama administration transition from paper to digital records. And of course, what happened along the way was we lost the hearts and the minds of our doctors and our nurses by turning them into typists and creating over a 50% day of just entering data. And so how might you imagine that we can improve that situation? Of course, natural language processing and AI can listen, and I'm talking about ambient listening, the kind of Alexa, Siri kind of technologies that then can fill the electronic health record with structured and unstructured data so that the clinician then simply has to review and sign. And similarly, I can imagine that electronic health records as they exist today are radically going to be redesigned. And this means that it's a team-based effort. Think more of a Facebook approach to recording the data that we need, where you have doctor, nurse, family member, patient, all contributing to data, reducing burden. So there's no question the importance of AI and NLP and the importance of a almost social media approach to getting the data in is necessary to reduce burden.
So, John, one more. How soon would it be possible for doctors and patients to get to track everything about their health, from blood work to medication to fitness, through a connected platform? And who will in the coming days eventually own a patient's data?
Well, okay, you ask really interesting questions. So why don't we start with the last one first? The question is, who owns the data? I could argue that identified data is owned by the patient, right? So I've spent much time in India, and in India, you're carrying your record with you. It's yours. Whereas I could argue that de-identified aggregated data is something that a healthcare system might steward for drug discovery, for evaluation of new treatments and cures. So it's a combination of ownership by the patient, stewardship by an institution for de-identified aggregated data. As to the coming together of all these data sources, the challenge, of course, is we have a flood of new data sources. The devices you wear, the things in your home.
Oops. I think we've lost him again. We've lost him again.
Is Andrew online? So I'll turn to Andrew and ask him, will technology make individualized medicine affordable and expand its scope in the next decade? And what do you think are the pitfalls of individualized medicine?
I'm sorry, can you repeat that last part?
Will technology make individualized medicine affordable? And will that scope expand in the coming decade? And what are the pitfalls of individualized medicine?
Again, wonderful question. So I guess there were three parts. Where will individualized medicine become affordable? I think so. The cost of a variety of large-scale omic testing platforms, whether it's a genome or transcriptome or proteome, those are not cost prohibitive today, and their price will come down. Will it become scalable? Yes, it's an infrastructure issue, and I think many groups, including Mayo, is developing the infrastructure to make that more scalable. Now comes its precision, and what are the pitfalls? So there is so much more to a disease than genetic profile, transcriptional profile. There are things which are difficult to quantify and aggregate. I'm thinking in terms of environmental factors, the impact on the epigenome. So right now we're at the stage of finding association between genomic variant A or transcriptional profile B and the penetration and or phenotype of disease. As that gets more robust, I think that will lead to a suite of treatment options, which then, based upon patient need, patient desires, and physician input, can be triaged and prioritized. So I think it's the omics revolution is an input that guides the next decision tree.
Okay. Interesting.
Let me bring Pankaj in here, Amitabh, if you don't mind.
No,
I can't, while I've said we should talk beyond the COVID-19, but I can't let go of the opportunity with Pankaj sitting bang in the middle here, because this is a question which is being asked all the time. What's going on with HCQ, because you're a big manufacturer of this drug yourself, and what is happening to a real development of a vaccine which will get developed, approved, distributed, applied, and be available to all the citizens of the world. How far are we from there?
So I think, let me address the question on HCQ. I think what is important in any scientific discovery is that audited, authenticated data is available for people to really comment on it. Today, I think people are just commenting much before the data is actually in hand. And I think that is the real area of concern. So patience is what is required, because medical science, you just cannot decide something based on some stray data. You need to have sufficient data, auditable data, detailed analyze, and then one can say it. So today, I think in that process, a lot of people are claiming both the sides, and what is right and wrong, everybody is confused. So point is, HCQ has been used in the world for many years. We have been supplying a lot into not only the India market, but also the US market. We have not come across, we monitor the adverse drug reaction. We have never seen the kind of adverse drug reaction being talked about today in some of the articles. But again, I'm not saying that that is the final data, because my point would be, now there are clinical trials going on in different parts of the world, including India. And once those data will be out, we will exactly know what is the benefit of HCQ and whether there is any additional risk or not. The second point which you talked about is vaccine. I think people have not understood. A typical vaccine development cycle can go as long as 10 years. And we are now trying to reinvent that vaccine in few months. So it's very, very challenging to think like that, because the question is whether the vaccine will be immunogenic, whether it will be protective, and how long is the protection is going to be. Apart from that, of course, there are going to be any undesired effects of vaccine or not. Given that all, one would need time in clinical development to make this thing happen. So even if we hurry up in making that happen, the emergency use of vaccine cannot be permitted before beginning of the next year. That's the way I see it. And that's the way vaccine development will happen.
So Solomon, By the way, I should mention that everybody on this panel, while they may not be in India or Indians, all of them have some connection with India. John has done some wonderful work in Bihar. Andrew has been working with Indians and in India. Solomon is doing an amazing program called Smart Villages in the east, south and the east of India, and then he's taken it up to the northeast of India. Solomon, can you, in a 2-minute window, tell us why did you start this Smart Village program and what is it?
Yes, Smart Villages movement, we started this back in 2016 as a movement. It's an initiative of UC Berkeley because majority of the people in India live in villages and they need to be digitally connected. And with the digital connectivity comes all kinds of services, whether it's telemedicine or doing trade, selling things and buying things. And so the whole idea is to use platforms. So the way we define a smart village is it's a community empowered with digital technology and open innovation platforms to access global markets and services. So it's not building water tanks, roads, and all that, toilets and libraries. It's mainly building people by giving them digital technology and teaching them how to use it so they empower themselves and build the economy. And we started this in 2016. It's about 2 years later, this wonderful program our Prime Minister has brought in, which is Ayushman Bharat came in. So we experimented. We work in 8 verticals in smart villages, but let me just narrow it down to healthcare because that's what we are talking about today. And we use an ecosystem approach to do this. We had more failures than successes. And when this program came in, our Prime Minister's Ayushman Bharat, we said, this is an amazing program. It was well thought out. It has it is addressing all the needs of the people. It's addressing the 40% of the poor people. So we don't need to do healthcare as much, but however, it also had some challenges. And I believe that what we have learned over the last several years on administering these different technologies from Silicon Valley, digital, as well as platform-based technologies, I think we have a lot to offer to the program that the Prime Minister already has, because I know there are some challenges with this program. The great thing about this program is the world's largest state-sponsored health scheme with 500 million Indians in it. That addresses the 40% of the poor. 5 lakhs are given to each family per year. Both public and private hospitals can participate. 3-day hospitalization, 15-day post-hospitalization, diagnostic and medicine. I wish we had this program in this country. It's cashless payment services and no restrictions on family size, age, gender, or previous medical conditions, pre-testing for coronavirus even. So this is a great program, golden program, but some of the challenges of any new program is that, some of the hospitals that are not very honest are abusing it by giving fake fraudulent bills. So we have 171 hospitals now imposed a lot of fines, and 390 hospitals are under investigation, which means the Prime Minister's government has also wonderful controls in place to correct these problems and to make this one of the world-class programs. And I think that's where UC Berkeley, what we have learned on ground. Also.
Thank you. Amitabh, you want to take a question?
No, I just wanted to add on to what Professor Solomon has said, that actually Ayushman Bharat has 2 components. One is we have 150,000 health and wellness centers in rural India, which are digitally getting connected to the district hospital from rural areas, so that rural person can have access to the best medical advice from the district hospital. And secondly, we have an insurance scheme, which is the PMJAY, and which covers 500 million Indians. It's the world's biggest health insurance scheme, and it serves a population that equals countries. and at least 80% of the 107 million beneficiary families are in rural India. So it's a remarkable scheme which is having a huge impact on the lives of people. But I wanted to turn to John, because he left us midway and he was making some very, very important points. And I wanted to ask John, because the current decade will see much greater sharing of healthcare data for care coordination. And how do we ensure security of this data? And how will we have all information in one electronic platform and reduce the chances of medical errors?
Well, certainly. And so sorry for, pardon, I'm here. Can you hear me okay?
Yes,
Yeah.
Quite clear.
Very good. Yeah, internet backbone issues, I'm guessing. So here's the approach Mayo has taken. We have partnered with a cloud provider, and that cloud provider has given us a secure container. That cloud provider has no access to the secure container. We de-identify data and store it in that cloud container, and then invite participants and collaborators into their own secure container to access our de-identified data, so that there is no notion of sending anyone's data outside Mayo Clinic's control. So I think the notion of a platform, as you describe it, where some data is de-identified for discovery, some is identified for care, but controls are such that it is always within either an organization or the patient's direct control. It is not spread around as so often is the case today.
Wonderful, wonderful.
Right, thank you. We'll just take a 2-minute break and come right back with the rest of the questions for these folks. Just for 2 minutes, please. Welcome back. You are watching the Mindmine Mondays program of the Mindmine Institute and CNBC partnership. And we have an outstanding panel that's looking at the future of healthcare in all forms: connected care, customized care, genomics, what technology and artificial intelligence will do. And we have absolutely the top class experts with us here today. So let me go to Navtej Buttar. Navtej, you spoke a little bit about what artificial intelligence can do and what diagnostics can do. What about the tooling, equipment, the machines? How are they developing? Are they evolving at the same pace as the software side, or are they lagging in some sense? Because you do minimally invasive surgery all the time now, and that's getting more and more sophisticated, with less injury, less trauma, lower hospitalization time. So where do you see that going? And are you getting the full support from the hardware?
So it's an excellent question, Sunil. There is always a lag in developing hardware. I mean, I'm going to take an example of hospitals of the future. So, if you talk to our software colleagues, and if you talk to those who want the hospital of the future, we would like to change the paradigm completely, where instead of patients coming to hospitals to heal, we will be taking healing to the patient. But in order to do that, the hospitals need a ton of the data, the support, the infrastructure, because what we're doing currently is that we take a patient from point A to point B to point C, wherever a hardware is installed. They go to the CT scanner, they go to the ICU. That's where the teams are sort of coiled around that. The issue is that if we want to get to this future, because many of the common things will just be done at home or at ambulatory centers. So in order for patients to be here, they'll be here with high acuity. So with the high acuity, things will very rapidly change. And if they're rapidly changing, we need to sort of mobilize the teams and mobilize the resources to where a patient is. And, of course, we're hoping in the next 10 years, through robotics, through drones, through all sorts of different things that we'll accomplish. But there is still ongoing challenge. And, and John can comment further on that, that I think the hardware is always takes a longer and a lot of investment.
Amitabh?
So John, tell us, how will hospitals be designed in the future? And how will capacity for intensive and critical care be integrated into the hospital layout and user experience? Last year, Walmart opened its first health center, a medical mall where customers can get primary care, vision tests, dental exams, root canals. Is healthcare going to go the Walmart way in the future?
Well, I think the answer is it's a combination of all of the above. So let's think about what COVID has done in the last 12 weeks is accelerated telemedicine and telehealth by 12 years. And so hospitals that were doing 50 virtual visits a day are now doing 5,000. You're seeing a spectrum of care at a distance services evolve. From the asynchronous, is this mole cancer? I'm going to send a picture to a specialist, to an EICU, care delivered at a distance, even for very intense care, and even in the middle, advanced care in the home or alternative settings. So what I see is bricks and mortar is very much evolving to more a clicks and mortar approach, with the expectation by many patients of very different kinds of services being delivered remotely than ever before.
Yes.
So Pankaj, tell us, since you have a distribution network right now of pharmaceuticals, you run one of the largest pharma companies. Is that a vehicle on which healthcare services themselves can ride? How do we actually increase our reach and improve the reach in the parts of the world where we do not have reach right now, including many parts of India?
So I think one of the important things which is going to happen is that the physical meeting and physical discussions or physical consultations, all these are going to take a backseat, and more remote kind of consultation, remote kind of testing using devices to diagnosis, all these are going to be used more and more as time will progress. And of course, India having such a large number of mobile phones, which are smartphones, and a great network of mobile network, it should be possible to use it. So what really is going to happen is that the pharma companies will start collaborating with the healthcare professionals to provide teleconsulting solutions, because India has large number of individual practitioners, unlike group practices or hospital practices which prevails in the Western world. And these individual doctors would basically get support from pharma companies to actually start doing this teleconsultancy much more. So I believe number of pharma companies are trying to develop teleconsultancy solution, through that they can reach larger number of patients. I think the same as John said, In the COVID time, teleconsultancy has become very important, and I think greater acceptance has already happened in India. So I clearly see that beyond next normal, as we talk about next normal, this is going to happen, and pharma company will participate in a big way in changing this healthcare scenario in India.
Sunil, I wanted to add on to what Mr. Patel has said, because India has built the largest unique identification infrastructure. What we call 1 billion plus Indians have biometrics. Over 1 billion Indians have bank accounts, and over 1 billion Indians have mobile phones. And this has helped us to create what we call the JAM Trinity, the Jan Aadhaar Trinity. And India, with its large market for both network equipments and handset, has played a very key role. And my view is that we've taken the initiative for creation of a national health stack to make both personal health records and service provider records available on cloud-based services using the net. This national health stack will leverage big data analytics and machine learning all the way to artificial intelligence. And it will help us to significantly bring down the costs of health protection in a very big way, and reduce disparity by ensuring a totally paperless, cashless system for our beneficiaries. And this is what we are implementing through the national, the Ayushman Bharat scheme. So all this, when you look at the big push for telemedicine at the beginning of the COVID-19, we came out with the guidelines, and I think the face-to-face communications will be a thing of the past and future. We'll all be clicking photographs, sending to our doctors, taking advice on telemedicine, the national health stack, the Arogya Setu, and the national Ayushman Bharat will all drive health penetration in a very, very big way in India in the coming days.
Thank you. So let me ask you, Solomon, you are a business professor. You're a professor of innovation, actually. That's even more interesting. What do you see happening to the business model of healthcare? One complaint we've heard country after country is that the model is broken. There are very few countries in the world which can say, I have a model which functions fully, it's viable, it's affordable, and it gives best quality of care. All three are all fully met. In 10 or 20 years, do you see a model developing based on all of the conversations we're having right now, new technologies, lower costs, easier reach, more bandwidth available, more schemes and plans available set up by regulators and governments? Is that going to be the business model going to see an innovation as well, or is it just the technology of care?
And I think, I usually say to my students, technology is useless unless there's a business model to drive it. And when we are working in these villages for the last several years, we are finding what would be the best business model that will give the highest value at the lowest cost. And we believe in the ecosystem approach, which means many companies come together and work in complete collaboration to eliminate costs, save time, speed to solutions, and share the risk. Shared economy is one thing that's moving forward. So one of the things that we feel that in a few years from now, people will be far more aware and be educated about their own bodies, about what they have. In villages, people don't know what they have. The first time when they know what they're predisposed to, then they start taking care of it. And I believe this wonderful insurance scheme that a very successful one that Prime Minister has put in, I think if we make the people more accountable to go and get regular checkups and make the insurance contingent upon that, we believe it'll be very highly successful. That's one thing. I think that's one thing. The second thing I would say is the digital platforms. I think digital platforms, which we have been experimenting in the villages, I think will be highly, very useful, because they improve the speed, lower the costs are even eliminated, and they bring the connectivity from the doctor and the patient together much faster, much quicker, and eliminating all the recent middlemen. So I think the ecosystem approach digital platforms, and awareness. I think all of these are going to happen because we're mobile devices now, and I think we're looking at a very bright future.
So Andrew, let me ask you a question which is normally in the domain of science fiction movies, or at least it used to be. More evolved genomics blueprints are available. Platform care is here. Software to do that is also available. Will an intersection of these allow us to live happier, healthier, and longer?
Oh, absolutely. So I foresee a future whereby before you have your encounter with your physician, you have a genotype performed. And that genotype will inform your risk for disease, possibly if you have a disease, what drugs you can take and what drugs you can't take. And I think that's going to be as much of a piece of information that patients and providers will use to direct where their care goes in terms of what disease to look for and screen for and test for, what drugs to use when you have a disease, and look at future risks so that you can target preventative screening and or therapy. Another comment I wanted to get back to is the question that was asked to Dr. Patel about how pharma and healthcare is starting to intersect. So I do a lot of work with a variety of pharma companies, and what I've been seeing is that many of the big pharmas are starting to make remote monitoring tests and diagnostics to help identify those patients who can benefit from their drugs. And I've seen that occur in the ophthalmology space, in the hypertension space, in the cardiology space, and oncology space. So I think that the pharma-patient interaction is going to increase and really contribute to the benefit and health of society.
Hey, and if I could add to that very briefly, so I am the second human sequenced in the Personal Genome Project. So I have lived for almost 15 years with knowledge of my risks. And how has that materially changed my care? Well, it turns out I'm a vegan, right? So for 25 years, have not even ingested cholesterol. My genetic risk for heart disease and stroke is extremely low, but my risk for prostate cancer genetically is very high. My primary care doctor about a decade ago said, stop cholesterol testing. You're a vegan with little risk. Stop ECGs, but we're going to do PSA testing despite the fact the New England Journal says don't, because for you, your genetic risk is high. So in effect, my care has been customized to be cost effective with a better outcome because of the sequence, just as Andrew has described.
I think that in some sense is the biggest step forward, that you're able to customize each individual's healthcare, not just the healthcare, but the prevention itself gets customized. Amitabh, over to you.
No, I wanted to ask, because this is a very fascinating area, and I wanted to ask John, because, because a number of people have actually raised ethical concerns related to gene mapping and individualized medicine. And genetic profiling and targeting on specific characteristic of each individual can also open up a Pandora box on privacy issues. And therefore, what are the challenges in this area, John? With all your experience, can you tell us?
Well, of course. So the question is, what is a de-identified record? Well, I'll remove your name, your address, and your phone number. Oh, and then we have to look at the text, because if the text says, this patient is a famous business expert from India, oh, well, that could be identified. What about the genome? What's a de-identified genome? Well, I'll give you an example. So I just presented to the board at Mayo a look at what a de-identified genome might be. We used my genome as the exemplar. I am homozygous for BRCA1. What does that mean? So I carry a risk of breast cancer genes. Well, I'm a male, so it turns out it doesn't really affect me, but it could affect my offspring. And it turns out it's a relatively common gene. So saying it's a male with BRCA1, not identified. You start looking at some of the alleles, some of the variations I have, some are really obscure. And that combination of a bunch of very obscure variations is in fact unique to me. So when we look at genomic data, we are going to have to do what we think is a reasonable de-identification. Show only as much of the genome as is reasonable, so you cannot re-identify the patient with low effort. And that's our challenge.
Thanks.
I'd add on top of that, that it has huge implications for insurance coverage and the whole definition of pre-existing condition. So I think there will need to be compensatory reform in insurance coverage to cover these kinds of issues.
So,
Can I just add a point
please
here?
Go ahead. Please go ahead.
So I think there is this debate about this data privatization, data safety issue, and at the same time need of a data, because you cannot reach to AI till we have sufficient number of data available so that we can really do meaningful conclusion out of it. So one need to decide between the two and decide what is more in the help for the people to get benefit out of it than to just look at, okay, data privatization is more important and that's why data should not be shared. If you don't share the data, if you don't have the data, then you can't just find out anything about in the AI area.
So, Mr. Patel, I also wanted to ask you that, I wanted to turn to India a little bit and ask you as to how will the healthcare landscape look for Indian firms in the next decade? What kind of vision should companies of your size have for, say, 2040 and beyond? And, what kind of, how do we bring in more and more innovation in this area?
So, sir, I think there are, if I see from pharma industry perspective, Indian pharma industry is today like a kind of a pharmacy of the world, because offering large number of generic drug, and during the COVID crisis across the world, the medicines have been supplied. There are no short supply of medicine. So that capability Indian pharma industry already have developed. And as you said rightly, innovation is going to be the next step moving forward for Indian pharma industry. We have a great opportunity in terms of doing innovation, because we have huge data available in India, a huge patient pool available in India. Clinical trial can be done much faster and quicker in India. And we need to, we can also actually do many things quickly in India compared to what happens outside India. What only the hurdle today we see is some kind of regulatory system which have been prevailingly before, because I believe government now is looking very seriously about also easing out the regulatory framework, creating kind of an ecosystem for more innovation to happen. So most of the pharma companies whom I've been talking to have been thinking about much more aggressively about innovation, and they're looking forward for doing many innovation. Today, if you see COVID vaccines, at least there are 30 different people who are trying to develop vaccine. And I believe that at least few of us are going to go into clinical trial very soon. So clearly we see that India has the capability, and I think given the opportunity and given that, India will start developing. And I say sometime very internally with the people, we have benefited a lot in India because of the medicine which were developed in the West. It's time for us to pay back. So we have to develop, we have to innovate and give it back to the world. That's the way I
was going to say that, Pankaj Bhai, you even let go of your advantage of API to China. So we do need to do some of that ourselves. I have a question for Navtej. Navtej, we are all discussing technology. It sounds like a cold clinical process that we are heading into. The contact between human to human, the caregiver, the connection that you have with the nurse and a patient, the conversation that you have with two human beings, is that going to go missing? Will this just become mechanical like a machine for care?
The short answer.
You are both a very competent doctor and a wonderful human being. I know that for a fact, by the way. So how do these two stay connected in the future?
Thank you. I think the short answer is no. All the technology that we're talking, it seems like, as John pointed out, or Mr. Patel, that these things are actually assisting us to do what we want to do. Take administrative burden out. As Andrew pointed out, pick up the right medication, give the right medication to the person. But the human connection, even if you're talking about AI, sure, a lot of AI will be likely will become automated, but it will still need human input. It will still need that message to be passed to the patient, to explain to the patient what that means. In my view, it will actually allow us more time to spend holding a hand of the patient, because many of these, the technologies that we're talking, you miss certain micro perceptions, how patient talks, how patient's tone changes, what are the expressions, is there fear? So all those aspects really need a human touch and human engagement. And so in my view, I think in 10 years, we probably will have more time to actually connect with our patients and have a better bonding.
That's wonderful to hear, because it's a bit of a question still in my mind, because if you look at that volume that we're planning to address through technology, will the doctor still have time to look at your micro expressions at that point in time is the question we need to address, because already in countries like India, relative to what you do in the US, etc., the doctor sees an order of magnitude higher number of patients a day. And the tools that we're talking about will allow them to multiply that. But it's hopefully a good direction that we're going in.
So Sunil, in real life, all I need is about 2 to 3 minutes of a quality time to really sort of have a, so the key conversation in any long half an hour consultation hinges on about 2 to 3 minutes of interaction. And if I can get every data and everything prepared around me and expend that 2 to 3 minutes or conserve that 2 to 3 minutes, I think there'll be an ongoing connection. Certainly there'll be, risk of, transactional healthcare, but I think we'll continue with the human touch.
So, this is a very fascinating area, and this is a very, it's a very fascinating subject, because one of the key challenges that remain in, the remote and backward areas of India is not about affordability, but about accessibility. And as we spread remote and virtual care, we'll have a huge increase in accessibility and timely medical advice. I wanted to, from the doctor's perspective, I wanted to know whether today's healthcare professionals, professionals like you, are you prepared and ready for this new era?
Once again, the short answer to that also is no. But interestingly, as John was saying that with this COVID situation, we very rapidly adapted to remote and virtual care in just last few months. So I'll start by an example. I received a call from a patient from India who's requiring blood transfusions every week, and what all she had, these tiny little blood vessels that were just breaking, and the patient was bleeding. So we arranged a video consultation. This is my first experience with arranging a video consultation across the ocean. And, our physicians reviewed the information that patient provided or patient had, the treatments the patient had. And after careful discussion, pros and cons were discussed, and they started the patient on Avastin. It's a medication that sort of we use for a compassionate basis to block the formation of these fragile blood vessels. So with that, patient, showed marked recovery. But, there are so many caveats there. First, particularly challenging is breaking the old habits. Remember, all of us physicians were in this for the last 30 years. For younger physicians, yes, it's difficult, easy. For some of the more seasoned physicians, breaking the old habit is difficult. Although we'll be more engaged, the infrastructure, as we earlier talked about, the hardware, software, that still does not exist to the level that we want. Workflow will be different. Barriers to entry will be there, although we most likely overcome all that. And the last one is the generational gap. The young patients Snapchat all day, they WhatsApp. So for them, it's just is a second habit. But what happens to your grandfather? Well, one can argue that the easy answer is the grandfather is, or grandmother is loved by the grandkids, and they will be there and they will be helping them. Because after all this will save travel, misery, waiting in line, likely getting exposed to COVID and all that. So, there are a lot of these issues that will need to be addressed.
So this is actually a fascinating conversation, and we could go on. But by the way, I don't know if you guys realize an hour has already passed. So a big thank you to all of you for this wonderful, wonderful conversation. I wish we had more time. Special thank you to Amitabh Kant for moderating this session. Normally, by the way, this is done by Mridu Bhandari from CNBC. A big thank you to her. And Shireen has done some of the sessions. But this has been wonderful. John, Andrew, Solomon, Pankaj, and Navtej, thank you all very much. I think this was fascinating to look at where the healthcare is going for us in terms of mechanics, technology, machines, software, and eventually, as you said, it's all about people. It's about each one of us, how we will approach our own health, our own state of health, how we look at people around us, and how we build a comprehensive system that's a caregiving system for taking the care that our health need. Thank you very much, and have a good evening.
Thank you.
Thank you.